I know, yeah.
welcome. Well, we have a full agenda this afternoon. And just to quickly give an assessment of what we're going to accomplish or try to accomplish during the meetings, we have two important activities of the commission that we need to move forward on. So we'll have those first. We'll take a short break because we need to reconfigure the room and then get back and then discuss the draft report of our analysis of the potential merger of Bethesda, Deaconess, and Lake. Following that presentation and questions and comments from the commission, we will take a vote to see whether we want to move forward with this draft, recognizing it is a draft, and there would then follow a period of time when we would receive comments and perhaps clarifications from the parties or from representatives of the public. We will have, following that vote, a public comment period. Several of you have kindly signed up for it. Given the number of individuals who have signed up and the fact that we recognize that it's getting late, we're going to ask you to limit your comments to 3 minutes each and to make the key points that you want to make. And for those of you who are anxious to sign up, Colleen is someplace. There she is. If you let her know, we can add to the list. Okay, so with that said, first I want to get a sense from the members of approval of the minutes of April 25th. Is there a motion to approve? Is there any questions or comments? If that, all in favor? Good. Okay, we're now going to move to a segment of our activities where we have, in previous meetings, we have instructed the staff to put together a small but significant fund to invest in new opportunities to help improve the healthcare delivery system. And to take us through that, I'm going to ask Commissioner Marty Cohen to take this on. Marty?
Thank you, Mr. Chairman. The Care Delivery Transformation Committee has 2 items for the Commission to consider for approval today. The first is approval of 15 grants under the Commission Shift Care Grant Program. If you remember back to last winter, we approved the use of $10 million in funding from the Distrust Hospital Trust Fund and the Payment Reform Trust Fund to issue requests for proposals for the award of grant funding to fund innovations that would essentially work to prevent avoidable hospital admissions, readmissions, and ER use. The Commission received 36 proposals across 3 tracks. Track 1 was addressing the health-related social needs that increased timely access to service. Track 2 and 3 were to address behavioral health. One track that increases timely access to behavioral health, the other that focuses on the use of medication-assisted treatment in ER settings in order to increase the rate of evidence-based opioid disorder treatment in those settings. Following that presentation of the grants, we will then take up a second item, which is the approval of new regulations on risk-bearing provider and ACO appeals. So let me turn it over to Kathleen Connolly, who will lead us through the grant process.
Thank you, Commissioner Cohen. Executive Director David Seltz is going to kick us off and then hand it back to me. Thank you.
Good afternoon. Great to be here with you all today. So I am sitting in this presentation for Katie Shea-Barrett, who is our Director of Care Delivery Transformation Strategies. Actually, unfortunately, home sick today, so I will do my best to step in. And Kathleen Connolly, who is the Director of Strategic Investment, will walk through at a high level our process, our design, and our review and selection process, and an overview of the summary of the recommended awards for your consideration today, Commissioners. So as Commissioner Cohen said, the Shift Care Challenge is our next investment opportunity, and was really focused on one of the key drivers of healthcare spending that we have identified multiple times in different cost trend reports and cost trends hearings, which is the avoidable use of acute care hospital settings, both through emergency department visits, revisits, hospital admissions, and readmissions, and have continued to see an opportunity to shift some of that care to more appropriate community-based settings that provide really high value care to patients, high quality care to patients, and also save the system of money, which is a key focus, obviously, of the Commission. So the Shift Care Challenge, as you can see on this slide, when we asked for proposals, we really wanted proposals that had and could demonstrate to us some of these key factors listed on the slide, that had a very strong care delivery model and impact, that had, as an organization, the type of leadership and support for the program. We also had a particular emphasis in this grant program on evaluation, because we do see that there is the potential for us to be able to contribute to the evidence base around what are meaningful and impactful interventions that can work, and using that evidence, be able to scale these promising innovations to not just the grantees that we're hoping to fund today, but to other organizations across the Commonwealth and across the country. We were also very focused on having a really strong alignment with the Commonwealth's priorities, but also making sure to have no non-duplication with other funding sources, particularly the DSRIP and the state waiver program. So that was a key focus of how we designed this program, was to be complementary to the tremendous work that the ACOs, Mass Health ACOs are doing, the tremendous funding that we have, and not to be duplicative in any way. We capped awards at $750,000, and we required that applicants actually contribute at least 25% of in-kind funding to those awards, and the rationale was really to try to help ensure that these awards will be sustainable in the long term, that the organization has a commitment to these interventions. So on this next slide, you can see the different innovative models that we asked for applications through. Commissioner Cohen, I think, summarized this well, so I won't belabor the points. But these are priorities that have, again, been identified through previous cost trends hearings and reports, as well as, again, very much in line with the Commonwealth's priorities in addressing health-related social needs, addressing timely behavioral health care needs, and also addressing the opioid epidemic by engaging patients in timely treatment to evidence-based pharmacological treatment. So just as a matter of our review process, we had a very thorough review process for the 36 applications that we received. We reviewed, a team reviewed and scored every single application that we received, and had consensus scoring on those proposals. I want to particularly note that we invited and had great participation from some outside experts who provided their expertise in this review and selection process. Most notably, our colleagues from the Department of Public Health and the Bureau of Substance Abuse, many colleagues from the Mass Health program and the program, Mass Health ACO program, as well as some experts that work in this community at independent healthcare foundations that do a lot of grant making. We scored each proposal, and we are recommending 15 proposals today for nearly the $10 million that was allocated for this program. So on this next slide, you can see here the list of the recommended proposals. As you can see, there are 5 that fall in the category of addressing health-related social needs, 2 that are really around addressing timely behavioral health care needs, but the remaining 8 are also around addressing behavioral health care needs, but with a particular focus of engaging patients in the emergency department who present with opioid use disorder. As you can see here on this slide, the HPC funding is in the far left column, totaling $9.7 million. really pleased to see that many organizations went beyond the 25% requirement of in-kind funding, such that the total impact of this initiative, if approved, would be over $15 million. And so excited to see that the dollars we're recommending would leverage additional investment by these organizations and their partners. On this next slide, the map, you can see just a geographic spread of the organizations across the Commonwealth and in areas that we know are of particular high need or underserved areas, particularly around behavioral health care. And also just wanted to highlight, we had a really, of the recommended awards, it's a really interesting mix of different types of organizations. We have many ACOs themselves, we have many chart hospitals, we have health centers, we have one of the recommended awardees is Community Care Cooperative, which is an organization of an ACO of community health centers that span the Commonwealth. And so a really interesting different mix of providers as well recommended through this swath of 15 proposals. So with that as just a high-level overview, I do want to give you a little bit more flavor of kind of what we're recommending in these 3 different categories. So Kathleen is just going to talk a little bit about each of these buckets of potential awardees.
Thank you, David. As David discussed, the primary aim for all shift care awardees is the reduction of unnecessary acute care utilization. You'll note that in the appendix of your presentation, there's a summary slide for each awardee that describes their primary aim, target population, and care model. The 5 recommended awardees on this slide are focusing on addressing the health-related social needs of complex patients and will be measuring related outcomes, such as numbers of patients connected to housing, food, and other needed social services. We are excited to have 4 ACOs and 1 ACO participant that will be implementing evidence-based initiatives that address health-related social needs with strong relationships with community partners and with plans for sustainability tied to showing value through reduced acute care utilization. As you will recall, strong community partnerships are a priority for this investment program, and we are pleased to see a wide range of partners represented. For example, the Bay State Healthcare Alliance is partnering with the Springfield Office of Housing, the Public Health Institute of Western Mass, the Pioneer Valley Asthma Coalition, and other community development organizations, as well as 2 regional ACOs. In addition to solid partnerships, as David mentioned, these and other shift care recommended awardees demonstrated robust evaluation plans that will contribute to the growing evidence base around care models that reduce acute care utilization by addressing health-related social needs. On this slide, we're recommending proposals to reduce acute care use through timely access to behavioral health care. As we continue to focus on providing access to behavioral health care, we are pleased to recommend these 2 initiatives that address the mental health and substance use disorder needs of their patients. Holyoke Health Center, with their partner, Behavioral Health Network, a community-based service provider in Western Mass, will continue their integration of behavioral health into primary care with their initiative to increase the engagement and treatment of patients prescribed psychiatric medications. Lowell General will expand access to opioid use disorder treatment by identifying patients in need of pharmacologic treatment and linking them to their Bridge Clinic for initiation and connection to outpatient care in partnership with Middlesex Recovery and the Lowell Community Opiate Outreach Co-op program. As the Commission will recall, per the legislative mandate, HPC is investing in models of care that expand access to opioid use disorder treatment by initiating pharmacologic treatment in the emergency department and connecting patients to community-based behavioral health services. The models that our recommended awardees will be implementing leverage the care model that was piloted and studied at Yale New Haven Hospital in Connecticut that showed strong outcomes in initiating and engaging patients in treatment, reducing emergency department visits, and reducing opioid-related mortalities. This slide represents the model whereby patients are identified in the healthcare setting based upon opioid use history, symptoms, or post-overdose, and then are assessed by a member of the care team who then engages the patient in treatment. Patients are then initiated on pharmacologic treatment and connected with follow-up outpatient care. Throughout these models, peer recovery coaches are part of the care teams providing support and navigation. Now I'd like to just show you the 8 awardees that we're recommending. We're so pleased to recommend these 8 awards that will expand access to pharmacologic treatment for patients with opioid disorder by initiating treatment in their emergency department and connecting these patients to community-based outpatient care. In addition to aiming to reduce emergency department use, these awardees will also focus on increasing engagement and sustaining patients in treatment. Here's our timeline for the Shift Care Challenge Investment Program. We are here today to ask the board to vote to approve these recommended awards. With the board's approval, we will move forward into the contracting phase. Throughout the contracting phase and the implementation of these initiatives, HPC staff will continue to coordinate and engage with our colleagues at MassHealth to ensure ongoing alignment and non-duplication of funds. We hope to complete contracting in the October-November timeframe with initiatives launching in December and January. Thank you for your consideration, and are there any questions that we can answer at this time?
Any questions or comments from commissioners?
Mr. Chair, I would move that we accept the recommendations of the executive director for funding of these projects as presented.
Okay, as you'll see on page 17, the motion that's listed here. Is there a? Yes, oh, sure,
I
please.
just want to confirm that in the in-kind contributions, that there is no district dollars, because that would not be in accordance with what we agreed to with the federal government.
We're working with MassHealth. They presented a template that we can use to track the funding and ensure
So just to be
non-duplication.
clear,
Yes,
none of the district dollars can be used as in-kind for these purposes.
we will ensure that.
I don't want to find myself in, yeah, I don't look good in orange.
All right, any other comments or questions? If not, I think we're ready for a vote. All those in favor? Aye. Opposed? Abstentions?
You might want to second in there somewhere, Stuart.
Yeah. Okay. All those in favor? Aye. Opposed? Okay.
Congratulations. Can I just have one comment? I hope that this system includes shared learning, just like the prior programs supporting if these places are provided.
Absolutely.
It's not.
Yeah, we're particularly excited for the initiation of pharmacologic treatment in the emergency department. We have quite a large cohort, and we'll ensure that there is shared learning across those models, and we'll do so for the other tracks as well.
Great, I can help with that, please.
Thank you.
Commissioners, thank you for that approval. I do just want to recognize that there are a number of representatives of the organizations in the room today who came today to hear this discussion and to see the approval. So I want to recognize representatives from Steward Healthcare, Mark Gerard, Manny Lopez from East Boston Community Health Center, and Chair of C3 is here as well. I'm not sure if Kevin Tabb from Beth Israel Deacon's Medical Center is here. I just saw Howard Grant from Leahy walked in. Dr. Karen Lasser here in the front row, a principal investigator at the Boston Medical Center. And many more are, I think, following along on the live stream. So thank you. I know that they are extremely excited to move forward on this program.
Thank you.
So next we have the approval of the appeals process regulations for risk-bearing provider organizations. And I'm going to turn it over to Lois unless David wants to weigh in as well.
Great. Good afternoon, everybody. We are here, as Commissioner Cohen said, to present on and ask for your approval of a proposed final regulation on RBPO ACO appeals process. First, we're going to just review again the statutory requirements and our regulatory process to date, and outline key comments that we received in the public comment period and our recommended changes to the proposed reg. So first, just reviewing the statute and the purpose of the regulation. As we've discussed many times, the law requires the HPC and its Office of Patient Protection to establish requirements for both an internal appeals process and an external review process for commercial patients of provider organizations that are certified by the Division of Insurance as risk-bearing provider organizations, or RBPOs, or by the HPC as accountable care organizations, or ACOs. These requirements do create novel consumer protections for patients. They're similar to the existing OPP rules with respect to carrier medical necessity determinations, but in this case, they apply to provider decisions about referrals, treatments, and access to care for patients for whom they are at risk. And so whereas on the carrier side, as we've distinguished many times, the appeals are about coverage of certain care, here the appeals are about access to a type of care or a type of provider. This next slide shows our journey here in the regulatory process from, it's almost like the history of the HPC back in the early days of listening sessions on RBPOs themselves back in 2013 that we held jointly with the Division of Insurance, to the issuance of interim guidance in 2016, and our extensive engagement with provider organizations after that in 2017 up through 2018, when we have been reviewing the quarterly reports of the provider organizations. The board advanced the proposed regulation in April for public comment. And these, throughout this process, we've held these key considerations on this slide as a guidepost, trying to advance these consumer protections of this very distinct process from the carrier process, to establish it in a way that can be flexibly implemented across the various types of provider organizations that are RBPOs and ACOs, and that builds upon now the successful implementation of the interim guidance and takes advantage of OPP's long experience in the carrier context in administering external reviews. And consistent with our process with carriers, allows us to continue to monitor the implementation through annual reporting. So we did receive feedback on the proposed regulation at a public hearing in May, and also through written submissions from a variety of organizations you see on this slide, including providers, health plans, and consumer advocates. And we've reviewed these comments, and as we discussed with the Care Delivery and Transformation Committee in June, we were pleased, very much so, that the commenters supported our approach overall in the proposed regulation, and really the comments focused on a relatively limited set of issues. So on these next slides, I will summarize those issues and our recommended resolution. So as to the effective date, some of the providers requested that we have at least a September effective date to give time to implement after the regulation is final. The earliest effective date after approval today would be in August, and we do recommend accommodating that request with a September 7th effective date based on when we file the regulation with the Secretary of State. Next, on some, we had some feedback on some of the time limits. On the time limit for responding to an expedited internal appeal, provider organizations requested that we change the proposed 3 calendar days to 3 business days to give them more time to administratively respond. We do recommend making that change. On the standard of review, as mentioned, we were pleased that the majority of commenters supported the review standard in the proposed regs, and we did receive a couple of comments though about the standard that the external review agency would use to determine appeals. As you recall, the proposed standard is whether the requested referral, treatment, or service is likely to produce a more clinically beneficial outcome for the patient than the one recommended by the RBPO or ACO. One carrier suggested that we use the same medical necessity standard as we do in the carrier side. One suggested that the standard should be more objective without recommending an alternative. But here, since most stakeholders felt like we struck the right balance with that standard, that is clinically objective, but also flexible enough to take into account factors applicable to each individual patient, we don't recommend changes to the standard at this time. We do recommend a clarifying edit suggested by health law advocates and others, adding a reference to timely access or treatment, which is something that we did contemplate. Another area that we did get some comment on were the costs of the reviews. Since the external review aspect of these appeals is new to these organizations, some providers did raise concerns about bearing the full cost of the appeal. Some suggested a patient fee to prevent or limit frivolous appeals, or to allow for a refund if the appeal is upheld by the external review agency. So our recommendation is not to require a patient fee at this time. There's no evidence to date that there will be many appeals at the outset, or indeed that they're frivolous. It's not required by statute as it is on the carrier side. And so this is something that we can revisit if it proves to be an issue going forward, but our recommendation is not to change the fee provision in the proposed regulation. And since we did get some questions about the external review agencies, well familiar to carriers, but just we can be more transparent about the external review agencies. OPP has just gone through a competitive procurement process, and we have 4 vendors. These are national organizations accredited by URAC, and they are iMedix, iPro, ProClear, and Maximus. And the average cost of a review is $500, non-expedited, or about $600 in the expedited review. As to notice, we do recommend some clarifying changes about how notice must be provided, and suggest an additional permissive method of providing that notice on patient portals. We did receive some comments around access to medical records in the context of this process, and we do recommend certain clarifications here. In response to some of the provider requests, again around time frame, we do recommend changing time frame for providing medical records to the external review agency from 3 calendar days to 3 business days, and for the expedited reviews from, we said 24 hours before, but recommend changing it to 1 business day in response to provider requests. We don't recommend, however, incorporating additional strict time mandates to provide medical records to patients before an internal or external review is requested, as that's out of scope, and providers will have existing statutes, federal and state statutes that they have to comply to in terms of responding to medical record requests. Finally, some commenters expressed concern that the discretion of OPP to review and revise a decision of an external review agency is too limited. Here, just like on the carrier side, the OPP director may seek retraction or revision of a decision based on clear factual or procedural error only. And we don't recommend changing this. Just like on the carrier side, limited discretion here is appropriate. The external review agency is the clinical expert, and that decision, OPP doesn't have the clinical expertise to second guess, and the intent of the process is to have a third party review it. So we do recommend a minor clarification here that procedural errors that are noted have to be material for the OPP director to request retraction and revision. And here also some commenters requested clarification about the binding nature of the external review agency decision for patients. So we do recommend language that clarifies that the decision is binding only as to the matter that is the subject of appeal, and there could be additional decisions by the provider organization, perhaps affecting the same subject area, but their clinical circumstances or other circumstances of the patient may have changed. So there could be future decisions of the RBPO that could be subject to appeal.
What, in terms of the changing from clear to material procedural error or clear factual error, what does clear factual error mean?
Typically, we see this on the carrier context if the decision names the wrong patient, or there's an error about which provider, the diagnosis. Those are things that we can send back often, not often, but sometimes do to the external review agency to make sure that they have the right patient, the right records.
So for the purpose of revision, but it would
Correct.
in order to change the decision, it would have to be a material factual error.
It's the material procedural error. So if there's a process change, but it has to be one that is material. That's right.
Thanks, Lois. Three questions. First is, can we have a look back in a year to see what's happened with the processes here to make sure that we haven't made a mistake in protecting patients' rights with you? I had some concerns about the access to medical record decision. I'm sure you've thought about it carefully, but I want to register them and just ask you a thing. First of all, for the expedited review, I imagine that would occur in circumstances where there's some real medical urgency. And is the move from calendar day to business day wise? If someone needs care on a Saturday, we might have just done some harm by mistake here. And so I was concerned that it's expedited. There must be a reason why it has to be immediate. And the second is the decision not to address the access to records prior to initiation of appeal. It seems a little illogical to me because the reason to have access to records prior to appeal is maybe to avoid an appeal, to make a decision that it's not warranted. And you say it's out of scope, so I guess my question is, so what is protected? If I start trying to decide whether to make an appeal, given the other statutory requirements on providers, how fast can I get my records, and are we really wise to stay silent on that?
So on the first question, absolutely. So as we've discussed before, we do require reporting, and so we will get detailed reports about the number and nature of the reviews.
Bring that to us in full session, please.
One of the differences here with carrier appeals is that in the carrier context, there is a sort of, it's often a patient's physician with access to medical records and the carrier with its own sort of clinical review of those records, and there's a difference of opinion as to whether or not something's medically necessary. And here, especially in the internal appeals context, it will be the provider organization who will be sort of reviewing itself, having an independent or sort of not the treating provider, but another clinician internally will be reviewing. And so they will have access to the medical records as opposed to the patient. So there's no, in the internal review context, it's the provider organizations themselves that are reviewing the medical records of the patient. At the request of the patient.
I get it, but we're asking here, the patient's got to make a decision as to what to do about the appeal. And this access to medical records has to do with, can the patient get the record, and how fast can they get it? I mean, this is something.
Right. The statute here doesn't address this issue, and so our ability to alter existing statutory access to medical records is not contemplated in this statute, and it's something that that I don't recommend changing in this context without legislative direction.
What about the business day versus calendar day for Exeter?
So in that case, are you talking about providing the records to the external review agency?
That's what the language has to do with here.
Right. And in that case, this is about gathering the records to send to the external review agency. It doesn't affect the time for the external review agency to render that decision. So it probably, it truncates the time for on the external review agency end, but not in terms of the decision affecting the patient.
What's the expected volume, do you think? 12 months, September to September, that we'll have in session, the numbers down as time will go. What's your guess?
That's a good question, but just a couple of data points. So in the year and a half that we've been tracking internal reviews, we've had roughly
Less than 200.
Across 20 different provider organizations, and we expect some significantly smaller portion of those to come to external review. We do, and most of the providers have expressed to us that they will be resolved internally before coming here, and that really is the goal. So some small proportion on the carrier side, likewise, out of the larger scope of internal appeals, annually we get about 350 external reviews, significantly 6,000 appeals, a significantly smaller portion go through the external review process.
So hundreds, not 10,000.
Correct.
Until ACO is taken over. And what for Exeter going to be expedited? Where?
Of the carrier appeals process, a very small proportion of it, less than 5%. And I think the total universe that it's our understanding is about 1.5 million patients who are attributed to risk contracts, and so given the 7 quarters of reporting thus far, I think it's 179 exactly. So that represents 1/10,000th of a percent.
Good, thanks.
You did clarify that this, or you did say that this does not include mass health.
That's correct. So this applies only to commercial patients, mass health and Medicare patients and other avenues.
So the last slide, we should acknowledge that we are pathfinding here. We will be the first state. Are there other states in the same process of moving forward? Have you had any contact with those?
To our knowledge, we're the first state to do this on the commercial side. Other states with Medicaid ACOs and others have different processes, but on the commercial side, this is the first in the nation. So in doing this, we do think that the regulation does advance that new consumer protection for patients, balances the administrative burdens on providers, builds on existing agency infrastructure, which our external review experience, as well as internal processes that provider organizations already have for addressing patient concerns. And we will work with carriers to make sure that there is a distinction between, to be able to screen out issues that are more properly in the carrier context. We will work with the providers and the advocates to make sure that all of our decisions here are struck the right balance, and we will get additional reporting to monitor how this is going.
And you will be coming back to us with when you get enough experience on how this works. Any other questions? If not, is there a motion to approve?
Mr. Chair, I would move that we approve the regulations as drafted, and I also want to acknowledge the wonderful work that Lois and Steve have done to really be thoughtful in the development of these regulations.
Is there a second to the motion? All those in favor? Opposed? Abstentions? Good job, Lois. Steve, thank you so much.
Thank you all.
All right. So our next issue deals with the budget for next year for the Health Policy Commission. David and his team came before the subcommittee and we grilled them extensively on these budget issues. So I asked him to bring before you the budget and the key issues that we talked about. So David, I'm going to turn it over to you.
Great, thank you. Doing the executive director's report a little bit out of order from our usual meeting today. But did want to just, before diving in, wanted to highlight that this meeting is our 206th public meeting of the commission since establishment. It was actually the 50th full board meeting in the 5.5 years since establishment. This is our 50th anniversary together. And if you do the math, that works out to be about a full board meeting every 6 weeks over 5.5 years. So thank you, commissioners, for your tremendous commitment. I'm going to skip through some update slides on the investment programs and certification programs, as those are standard slides in the deck. But did want to stop on slide 34 and just recognize again our incredible summer fellows who are students who come and work with us over the summer here at the Health Policy Commission as full-time fellows working on different projects across the organization. We had the most competitive application process to date this year with hundreds of applicants from across the country and just have a tremendous group of fellows who I think are in the room, and here you can see some of the schools they're attending, but did want to recognize their commitment and work this summer, so thank you, fellows. So moving on to the FY19 budget, so breaking news. On this first slide, and it's not updated in your presentations, commissioners, but on the projected slide, you can see that we do have the number from the conference committee report, which was just filed earlier this morning. And our line item, which is our main operating line item in the state budget, was funded this year by the House and the Senate and the conference committee at $8.6 million. As you know, this line item is assessed to hospitals, health plans, and ambulatory surgery centers who operate in the Commonwealth. The HPC administers that assessment, and that revenue is collected and deposited into the general fund such that the commission line item is essentially a net neutral in terms of the state budget.
David, it's a little hard for us to see that slide in the back. Can you give us the actual budget number that came out of committee?
Oh, sure. It is the same number that is the House and the Senate numbers. So there has been no change in the final conference committee report. That being said, the governor still has an opportunity to review and make recommendations on the budget, so we'll be following that process.
So it's 8.7.
8.76. Thank you. 8.769,931. So for our budget recommendation for fiscal 19, as Chair Altman noted, we did have an Administration and Finance Committee subcommittee meeting where we went through in some detail. This slide summarizes the 3 primary funding sources for the Health Policy Commission and our activities. We have the line item, as was just discussed, which was first came onto the budget in FY17. We administer the Distress Hospital Trust Fund, which supports grants to eligible community hospitals, as well as does support operating expenses, staff, consultants, technical assistance, evaluation, and other activities related to the administration of those programs. And then finally, we administer the Payment Reform Trust Fund, which used to be our primary source of funding before the line item. Now that trust fund does not have any payroll or staff attached to it. It is used solely for investment programs and technical assistance. And so you can see the recommendations. Truly, I think the punchline here from the recommendations is that this is a maintenance budget. This budget proposal will allow the commission to continue to do the work that we've been doing, and really is meant to be a very modest proposal in that regard. As you can see at the bottom, the line item does increase very slightly. However, we are actually projecting and recommending a reduction in expenses out of the Distressed Hospital Trust Fund. This is related to the fact that the CHART investment program, which was the primary investment, not the only, but the primary investment program run out of the Distressed Hospital Trust Fund, is winding down, and we do see the ability to reduce spending on things like technical assistance and consultants and some staff. And so on, to give a little bit, I'll walk through in a little bit more detail and then kind of summarize it all together. But the punchline is that across these three different funding sources, we're actually recommending a slightly smaller amount of funding than we had approved a year ago. So really quickly, on the line item itself, on slide 38, you can see the approved last year's budget versus the proposed budget for next year, and the differences. The differences here you can see are primarily in the payroll. This is driven in part by some shifting of payroll and staff actually off of the Distressed Hospital Trust Fund and onto the payroll. It does not reflect some amount of new hiring. We are fully staffed, and our hiring plan is truly just backfills. And you can see there at the bottom of the slide there is a fringe assessment which also will increase, and that is beyond our control. On the Distressed Hospitals Trust Fund, again, you can see here where we're able to appropriately resize our spending and effort, representative of the programs that are being run out of that trust fund, and have some reductions in payroll and professional services accordingly. So adding that all together, on slide 40, you can see FY18 approved versus what we're proposing for FY19. And it is actually a slight reduction from what was approved a year ago. Would finally note that this budget recommendation is based on our current responsibilities and authorities. As many know, there are ongoing discussions around potential additional responsibilities or authorities, both through legislation and through a ballot initiative. These are not contemplated nor included in this budget. And if those do come to pass, we would obviously revisit and be back before the board.
Okay, are there questions or comments anybody wants to bring up? Again, as I said, the subcommittee did go through it in depth and approved the budget, but I want to make sure everyone's comfortable.
So
Okay.
on page 38, if I look at 18 to 19, last box, you don't put my glasses on. That's never stopped me before. That's actually, is that not the 400, also the almost $500,000 is a 4.9% increase on general operating expenses? 494,000 over 10.1 million, that's 4.9% increase on page 38. Well, my page 38, go back.
Yeah, so I will, yeah, so so there's two things to look at here. One is the first yellow row, which is the line item itself, which increases by $290,000. That is
I'm
what I
looking at slide 38.
Oh, sorry. Here we go. Yeah.
494,000 over 10.1 is a 4.9% increase.
So yeah, so the line item itself grows by about 3.3%. In terms of total spending, and the employee fringe assessment is actually not included in the line item itself. It is assessed separately, and so if you do that math, I'm happy to accept your math. It's a 4.9% increase total. And that is included and accounted for in this slide, where fringe is included as well.
And I'm assuming this budget is, what percentage of the 3% is attributed to, I'm assuming winding down the chart? Or is that incorrect assumption?
On this one, that is the driver here.
How much was chart, how much of this is?
So the reduction that we are recommending for spending out of the Distress Hospital Trust Fund is a 29% reduction.
Right, right, but if you're doing an apple to apples, I appreciate that this is 3% lower, it's actually, it's $500,000 more almost in payroll and operating costs, and the lower part is because we don't have the chart. Is that fair?
Fair.
Okay. Other questions or comments? If not, is there as the chair of the subcommittee, I'm proposing the budget as just articulated by the executive director. Is there a second?
Second.
Again, any comments or questions? If not, somebody in favor? Second? Any opposition? Okay,
Please mark me as abstaining.
okay. Okay, the budget is approved with one abstention.
Great.
Okay,
Thank you.
all right. So it is now almost 1 o'clock. We're going to take a short break, no more than 10 minutes, to allow some physical change and any other things people want to do. But please be back by 10 after the hour. Thank you very much.
Final lap. Yeah, I think it's, I would anticipate someone I have is 12-4. That includes presentation. So we have the whole board meeting 12-4. I would say 1-4 is presentation of the findings, discussion, and then I anticipate that. Yeah. All right, I'm able to race. Perfect. No, I don't think so. Let's do the round. I imagine it might take us a longer than that. So, yeah, sure thing.
Ryan, you're all set? Water? Yay.
Thanks, just a pleasure. Thank you so much. I'm gonna wait till people walk by and then, yep, but I have parked a bit over here, so. Any cameras? Should we bring in some chairs then for people? Yeah. No problem.